Hello everyone, it's Jonathan, one of your hopefully favorite talking heads. Wanted to discuss with you some details about medications that are indicated for mood disorders, major depression and related conditions, as well as bipolar disorders. This is the third assignment scheduled to be conducted during week 4. And I'm going to review a few basic concepts for you, hopefully refresh your understanding of what you've read in the chapters of your textbook, and readying you for the week's assignment. There will be not only this video, but a second video featuring my colleague Bob Tauber and his introduction of an audio recording of 2 psychiatrists discussing the approach to selecting medications for people suffering from bipolar conditions. I think you'll find that pretty interesting. So that will be posted as well as this video. So first of all, let me just recap a little bit of background in terms of the conditions that we're talking about here. If you were to look at a graphic illustration trying to depict the mood of a person who's suffering from major depression. I'm going to hold up some beautiful works of art here, and hopefully you'll be able to see these all right. If you look along this side, this is a very high mood, a somewhat positive mood, neutral mood, which we call a euthymic, poor, low mood, and seriously depressed mood. Along this way is the flow of time. And someone suffering from major depression, clinical depression in its various forms, moves from a typically normal mood, feeling okay about life, into a progressively more severely depressed condition, which eventually resolves in most cases, frankly, without intervention. But we all know sometimes depression becomes prolonged or too intense, or the risk factors become too elevated, and intervention is necessary, whether that's talk therapy or medication or a combination of the two. So major depression is one of the mood disorders we'll be talking about. There's several others in the depressive disorder family. One of them is dysthymia, which is a protracted period of low mood, not as severe as major depression, often not requiring medication or talk therapy for the client to be able to function reasonably well. But there are instances where over this, by definition, is a low mood with other symptoms, as discussed in DSM, and you learn more about in your psychopharmacology class, lasting for a period of 2 years or more. But the application of medication and therapy, talk therapy, for someone suffering from dysthymia is often beneficial in terms of reducing symptoms and increasing functionality. The other family of disorders or conditions that we'll be talking about are the bipolar disorders. And those are very interesting. There's a number of related conditions, or somewhat different presentations even of the same condition of bipolar 1, which we'll talk about first. But by definition, a bipolar disorder is a very, very, it's an expansive mood, a positive mood, going from your normal euthymic condition into a period of abnormally elevated mood, which eventually subsides again. For it to be a bipolar 1 condition, this is a manic phase which lasts a week or longer and has a number of other features, as you'll see, of course, in your psychopathology text. It, by definition, is bipolar even if the client has never had or shown a period of depression. The assumption is that if a client has had a true manic condition, sooner or later they will have a depressive episode, and so they're already considered bipolar. There's unipolar depression. There's no such thing as unipolar mania as far as our diagnostic options are concerned. And the reason we're trying to recap quickly diagnoses is that if we don't have a clear diagnosis, then we are much more at sea in terms of having any idea of what the appropriate medications for the purposes of our class here might be that would be most beneficial for the client. So bipolar illness is a person who has one or more episodes of mania in bipolar 1 or hypomania, bipolar 2 in their experience, their history. Now, of course, many times people have a mix of manic and depressed episodes, and this is more typical. And let's remember that they're not equal in number necessarily. They're not equal in frequency, duration, or severity. Many times people have periods of plateau in between episodes where their mood is euthymic. Those could be minutes, hours, weeks, months, years, depending on whether the client is rapid cycling or normal. There could be 1 or 2 or 3 or 4 depressive episodes in between manic episodes. There could have been a couple of depressive episodes, and initially the client is considered to be someone suffering from a depressive illness, and then a hypomanic or manic episode intervenes, and we diagnose the client as having a bipolar condition. But remember that individuals, patients, clients we work with can have an incredibly different presentation in terms of the long-term history of their illness if they're suffering from one of the bipolar families. So here's an illustration of a client, hypothetically, who has several depressive episodes and then finally has a manic episode, and at that point we re-diagnose the client as being bipolar rather than just a depressive illness. We have instances where bipolar type 2 is the presentation, and this is a condition again that has at least one hypomanic episode in the client's life, no full-blown manic episodes. Your DSM will give you all the details of how to distinguish between manic and hypomanic. It's the duration and severity of the symptoms primarily. If a condition leads to hospitalization or incarceration, it almost automatically is considered a manic phase because of the intensity of the consequences of the client's condition. But bipolar type 2 is someone who is suffering from a vacillation between elevated, expansive, high energy states and depressed states, but the intensity of the affect is far less severe than in bipolar 1, and the duration, especially of the manic phase or hypomanic phase, is typically much is briefer compared to the manic condition in bipolar 1. So again, though, we have the possibility of periods of plateaus, normalcy, of potentially long duration in between episodes of depression or hypomania. So that's bipolar type 2. Cyclothymia is an even milder condition where there is just a cycling back and forth of somewhat elevated and somewhat depressed mood. And there are other conditions, diagnostic categories that you'll be aware of, but I just wanted to give you a quick overview of that. And then talk a little bit about what your book describes in terms of how the medications that are used to treat these mood disorders work. And basically, they're working by changing the chemistry of the brain, adjusting the functional amount of specific kinds of chemicals that we call neurotransmitters, how much of that substance or those substances is made available to facilitate the functioning of the neurons in a human being's brain. And as the book described, our brains are incredibly complicated, 100 billion neurons. So that's, what, 15, 20 times the number of human beings existing on the earth right now. each neuron has up to 1,000 connections to other neurons. So we're talking about 100 trillion connection points. And so it's an incredibly complicated network. And like a physical computer, it is the interconnecting of these different strands for information to flow that causes a lot of responses to be manifested in the person, not just thinking, but physiological responses as well. So your book has a better illustration of the idea of two nerves and the synaptic cleft in between. An impulse, a chemical electrical impulse comes down the neuron with a message saying, get stimulated, okay? and causes the release of specific chemicals that we call neurotransmitters, those little dots in there. They are loosed to travel across a literal physical, microscopic physical gap, the synaptic cleft, and when they float across and contact and connect with receptor sites on the receptor neuron, that triggers a discharge of electrical energy through the receptor neuron, which then flows down the course of that nerve, and when it finally gets passed on to its destination, it causes all kinds of responses, other actions in the brain. It can cause muscle contraction in the body. It can cause the release of other chemicals, hormones, and other things elsewhere in the body. So it's a tremendously complicated process. But the crucial point of attention in terms of psychopharmacology is finding medications that will precisely target specific neurotransmitters in specific regions of the brain that then control different responses in the human being. So we're in psychopharmacology, medications are being sought constantly and refined that are more and more focused on this particular effort. And you're going to see, of course, a fair amount in your textbook, a lot of details. It can be tough reading at times, but I would encourage you to hold on to this book as a reference for your future practice. We need to be able to speak with intelligence and understanding both to our clients and to physicians and other treatment providers. When a patient tells you, a client says that I'm on Effexor, you should be able to have some idea of what kind of response the doctor is expecting to see in that patient, and you can evaluate whether there's a good response being manifested, an inadequate response. You know what kind of side effects to look for. You may, depending on the relationship with the client and with the physician, be able to give some suggestions about ways to think of maybe an adjustment in medication might be worth the physician considering. So all of these things we'll be talking a little more about in future weeks in the class. But the key thing in treating depression is to understand there's a plethora of medications on the market that fall into several different categories. There's a couple that we won't pay much attention to because they're so rarely used now. One is the tricyclic antidepressants, which were among the earliest developed for treating this particular condition. They're rarely used now because of a fairly high side effect profile. Then there is the monoamine oxidase inhibitors, MAOIs. They again are rarely used because of one specific serious side effect that required very careful monitoring of the clients' their dietary habits. If they ate too much of certain foods that are not uncommon, there could be a potentially catastrophic spike in blood pressure that could have fatal consequences. And so those categories of medications are certainly not first-line choices in today's treatment of depression. They are occasionally used when other medications, newer medications with lower side effect profiles, are not showing any efficacy in a given individual. But for the most part, we use selective serotonin reuptake inhibitors or selective norepinephrine reuptake inhibitors, and there's a couple of medications that selectively affect both the serotonin and the norepinephrine and prevent their reuptake. So the reuptake, just to remind you, I won't pull up my funky little drawing of neurons again, but when a neurotransmitter is released into the synaptic cleft, it essentially floats around in that space until it goes through one of at least three processes. One process is it drifts over and by chance bumps into a receptor site with which it bonds on the receiving neuron, and when that happens, it begins to trigger a response in the receptor neuron. If enough medication gets, or enough of the neurotransmitter gets to the receiving neuron, it crosses the threshold of excitation and a nerve impulse travels down that receptor neuron. Some of the molecules of the neurotransmitter, while they're in that limbo space of the synaptic cleft, bump into something that deactivates them or destroys the molecule, and so they are essentially ineffective and destroyed. Others drift around, happen to drift back to the upstream neuron from which they were released, and they are reabsorbed because your body tries to be a good steward of its inner ecology and not waste resources. So those neurotransmitters are reabsorbed into the nerve and repackaged for future use. So the reason a reuptake inhibitor is beneficial, we want to increase the stimulation of certain nerves to help treat symptoms. And so the more neurotransmitter that successfully jumps this gap and finds a spot on the receiving neuron that it can trigger a response in, the more excitation the patient's nervous system is getting, and ultimately we see some positive change in their clinical picture. So what we want to do is give the neurotransmitters as much opportunity as possible to find their mate, so to speak, in the receiving neuron. And so we want to give them those molecules as much exposure, as many opportunities to bump into the surface of the receiving neuron and by chance connect with a molecule that they click with. Essentially, the shape of the molecule and the chemical composition of the receptor site and the neurotransmitter have to match. It's a little bit like modern keys, where there's both a physical key that has to fit into the slot of the lock properly, and there's an encoded chip in there that has to be read by the lock mechanism before you can unlock and turn on whatever piece of equipment we're talking about. So the neurotransmitter chemical's shape has to be a mirror image of the shape of the receiving, the receptor site, and the chemical composition has to be exactly precise to cause the shift in the receiving neuron that triggers an electrical impulse. So I find some of the details fascinating. Other people find them confusing and overwhelming. But if we don't have that understanding, if somebody doesn't understand those things, the process of research and development for medications to treat these kinds of conditions is really impaired. So we want you to have a basic bit of understanding. Remember that there are three key neurotransmitters in our brains: serotonin, norepinephrine, and dopamine. These are all part of the family of monoamines, and that's where monoamine oxidase inhibitors comes from. Monoamine oxidase is an enzyme in us that destroys monoamines. And so you want to inhibit that with those older medications, if you stop or slow down the functioning of that enzyme, it keeps the neurotransmitters alive in the synaptic cleft longer and gives them more opportunity to trigger a nerve impulse in the downstream neuron. So the different medications have different side effect profiles. They focus on impacting different parts of the receptor neuron. Your book talks a fair amount about that, and that's why the various medications have slightly different applications. They're tolerated differently by different individuals, and getting a better understanding of them is really important, especially in terms of which receptor sites they act on, which neurotransmitter they tend to increase in the client, and what their side effect profiles are, because the best medication in the world is not going to be helpful if the client doesn't want to take it. If they have a side effect of excessive sedation and they feel so groggy that they won't take their medication, then we have no benefit for the client. So becoming more aware of those features is really important. Even though we're not prescribers, we help to monitor the client's possible need for and response to whatever medications they are taking. So your text in the flaps inside the book have some very good summary information on both how strongly these different medications affect the different neurotransmitters and what the typical side effect profiles are, especially in terms of sedation or activation. And so I'm going to sign off in just a moment here. I want you to listen to and watch Bob Tauber's presentation of the discussion between two psychiatrists about treating bipolar illness. It's a much more complicated medical problem than just treating the depressive disorders. I think you're going to find it interesting, and it'll give you a little insight into the art form behind providing psychiatric services for people with bipolar illness. I just want to ask you, if you've got questions about things, please don't hesitate to email me. I'd be happy to try to respond one-on-one to things, either by email or we can arrange to talk on the phone some. I know this background material sometimes has been a little dense and might be difficult to really grasp. We don't have to be expert in it, but it's good for us to be familiar. And I think you're going to like the next phase of the class where we're starting getting into specifics of medications and diagnoses. So good luck with this coming assignment. And like I said, please don't hesitate to call or write. Bye-bye.